My name is Dr. Nick Hicks. I'm a doctor with a training in general practice and public health and a long-standing interest in improving quality of care, health policy and healthcare systems. Most recently I've been Chief Executive and Director of Public Health of NHS Milton Keynes, and I'd like to tell you a bit more about an innovative approach to commissioning health and social care that we've called Cobic, or Capitated and outcome-based incentivised contracts. The job of commissioners is to turn taxpayers' money into better health, fewer inequalities and access to great services. My background is as a doctor with a public health training and a general practice training, and I've also ended up doing a lot of work on health policy, healthcare systems and eventually running a primary healthcare trust as a commissioner. I found in trying to commission in the NHS that the way we were expected to commission, by buying outpatients, inpatient operations, inpatient procedures, in other words measures of activity, using that as the currency often made things worse. It was very difficult to make an obvious metric between the activity we were expected to buy and my value chain as a commissioner. Worse than that, by putting money in for activity and paying providers for activity, it meant that whenever people wanted to improve care by moving care from one organisation to another or from another place to another, actually the financial incentives made life much more difficult for them. So lots of innovations that people recognised would improve care were blocked by the way in which we bought them. So my experience of commissioning for activity was that we fragmented care, we disengaged clinicians, we didn't talk to the public enough and let their values drive and focus us on the outcomes that they wanted. And in general we locked the system into a poor value, high variation mode. That came to a head when we were talking about a substance misuse service in Milton Keynes. It was an average service, but largely focused on the hospital. And a lot of people wanted to change the way it was provided and knew how they'd like to change it. But with our payment system, in which we paid for outpatients, that change was very difficult to bring about. But when we sat down with our partners and began to say, if this was a good service, what would it be doing? People began to tell us very quickly that actually the service would keep people in their jobs, it would keep people in their houses, it would give the courts a medical disposition when they wanted one, it would pick people up on day one when they came out of prison off drugs, not day 21, by which time they're back on drugs, and so on and so forth. And at that stage we said, well, if that's what we want, why isn't that what we buy? So we tore up the existing contracts and tendered for a service based on a capitated sum of money, but incentivised to provide the sorts of outcomes that the public and our partners wanted. We got 40 expressions of interest, 10 real bids from private sector, third sector and the public sector. We let it to a third sector organisation, a charity, and they have transformed the service very quickly. The service is no longer as centralised, it's much more integrated, the staff are much more focused on the needs of their client group, the public like it, the probation service like it, and importantly as well, we save 25% at the same time. So we've spent less and we believe got a better service. We think there's a model in that in the way in which we commission services. We think that the principles of combining capitation and outcome in the same contract allow commissioners to put the right incentives into the market in a way that unleashes the potential of providers to transform healthcare. Quite a number of CCGs and others have approached us to find out more about Cobic. If you'd be interested in finding out more, or if you'd want to work with us to consider whether it's possible to let a Cobic style contract in your area, please don't hesitate to get in touch.